something called pearls in retina disease management. You can listen to some of the senior people and some take-home messages in managing different common retinal diseases. I have Dr. Meena Chakravarti, one of the senior most retina surgeons here, to give the talk. I also invite Dr. Gopal Pillai, Dr. Thomas Cherian, Dr. Biju Raju, Dr. Prakash Ashok, Samya. So we will be talking about some of the relevant topics for retina practice, and I hope you will have some take-home messages. Over to you, madam.
Good morning, friends. At the outset, I would like to thank Dr. Mahesh for having given me this opportunity. And as the only woman in the panel, I thought I would make my slides a little more decorative than the men, hence the pearls. Diabetic macular edema is one of the most common scenarios that any vitreoretinal surgeon faces in his or her practice. In the next few seconds, I'd like to share with you the options that I consider while managing a patient with diabetic macular edema. My first and foremost emphasis is on systemic control. Know your patient's diabetic control and what medications he is on. For it's well known that worsening of the systemic status is equivalent to worsening of the ocular health, and a 1% reduction in HbA1c values translates to a 25 to 38% reduction in the sequelae of chronic diabetes. The standards of metabolic controls are different in different clinics. These are the standards that I have for my patients. HbA1c value of less than 7%. I'm quite strict and I check each time the patient reports to me for follow-up. A BP to be maintained between 130/80, less than that if possible. A fairly normal lipid profile. And I also take a look at the renal status and refer back to the nephrologist whenever there's a need. Be aware of the drugs that your patient is taking. If they are on glitazones or semaglutide, there is chance that the diabetic macular edema can worsen. Have an idea of whether the patient has had a cardiovascular event or an acute thromboembolic episode in the recent past, which will guideline you to the kind of drug that you can use for the intravitreal injection. Also find out if your diabetic patient is pregnant or breastfeeding, in which certain drugs cannot be used. Semaglutide is presently the wonder drug on the block, the new kid on the block, a widely used anti-obesity and anti-diabetic drug, which causes non-arteritic anti-ischemic optic neuropathy and worsening of the diabetic macular edema. The pearl number 2, my take-home message, is that laser still has a place in the management of diabetic macular edema. And if it is a non-center involved diabetic macular edema, it can be a standalone therapy and can also be used in combination with the intravitreal injections. If you do not have the subthreshold or the micropulse grid laser, be happy that nearly 66% of the world's population uses the standard laser. Laser also has a role in eyes with extensive peripheral capillary non-perfusion areas where a peripheral panretinal photocoagulation would result in resolution of the recalcitrant diabetic macular edema. Pearl number 3 is a choice of intravitreal injection. The protocol that I follow is that I start with an anti-VEGF, check the patient's response every 4 weekly. I expect a 20% reduction in the central retinal thickness and at least a 5-line improvement in vision before I call my patient a responder. I follow up the patient every 4 weekly. And if at the end of the first year, the patient needed more than 6 injections, I would shift focus of my therapy to start using steroids, such as in this patient. in whom at the end of 16 months, by the end of 2 years, the macular edema could be controlled. There are certain ophthalmological and systemic factors which can be taken into consideration while deciding on the drug. If you have an associated PDR, VEGF is a drug of choice, and Nosudrex implant would be of choice in a vitrectomized eye. If there are inflammatory biomarkers like hyperreflective foci, both in the retina and the choroid, a subfoveal serous retinal detachment, then a steroid would be a choice. If the patient has an associated glaucoma, I'd be a little cautious in using a DEXA implant, but it can still be used. The systemic factors that I consider are the history of a recent cardiovascular event, a thromboembolic episode, and if the patient is poorly compliant to follow up, I'd use a Nosudrex. I'd use a Nosudrex implant. The most commonly used anti-VEGF all over the world is still Avastin. 66.3% of the patients in the United States still are given Avastin. This is the results of the global trend by the American Society of Retina Specialists. And if you look at the toolbox for the management of diabetic macular edema from 1986 to 2024, what is new that we have in 2024? We have the Vabysmo of faricimab, aflibercept 8 milligram from 2 milligram, and we have biosimilars. The biosimilars can be used. They are as strong in durability as the original drug, but they have a shorter track record than the drugs that we have used for the last 15 years. So what is the role of faricimab and aflibercept 8 milligram in 2024? They have strong durability, but not stronger durability in the management of diabetic macular edema. They do not reduce the visit burden, even though they have a dosing frequency of 12 or 16 weeks. And although they cause a greater volume reduction, greater resolution of the hard exudates, this did not translate into better visual improvement. And as switching agents, there is no evidence that they do better. Only 49 to 50% of the patients are early and consistent responders, and we have poor responders who will either require continued therapy, switch to another anti-VEGF agent, switch to an intravitreal steroid, or combination of both. It is left to your choice and decision as to what you should do. But please bear in mind that the first 2 years are the periods where maximum response can be obtained. Subsequently, the visual results taper off. And if you have a patient who has a vitreomacular interface abnormality, or even if a patient who has a diffuse macular edema who is not responding to any other medication, vitrectomy would be a very good option since you're removing the vitreous sump. As in this patient with very significant diabetic macular edema, where a thick, taut internal limiting membrane can be peeled off, like what you do in a compartment syndrome, like the carpal tunnel syndrome, you de-roof the compression abnormality. And this is the end result in this patient. We could achieve a retina which is relatively quiet. But please, last but not the least, please bear in mind that loss to follow-up is seen in about 40% of our patients. Counsel the patient and try to keep them with you. I thank you very much for your patient hearing.
Thank you, madam. We have our next talk by Dr. Thomas Cherian. Madam, in your 30 years of practice, what is the commonest mistake that medical retina people do in managing DME? What do you see? Because a lot of people are doing medical retina in Kerala. And what is the commonest mistake they do? Irregular treatment or improper assessment, or what do you think is the...
What I feel...
On.
What I feel is that you inject too frequently, too many injections. I recently saw a patient who had taken 20 injections in each eye, and with one biosimilar, he developed endophthalmitis. What they started treatment was at 6/9 vision, and it presently blind in that eye. So inject when necessary, but don't inject too much.
In other words, what madam is telling is DME is a pardonable disease. Unlike AMD, you don't have to be very aggressive in treatment, like monthly injection. If you don't inject, it will become a scar, nothing like that. AMD, you have to be a little aggressive. DME is a you have to assess the response in 2 or 3 injections and then only go ahead with further treatment. Look for biomarkers, that is very important. Gopal.
Number 2, madam, you said that too frequent injections is a problem, but let me ask you, which is the injection? Like in diabetic macular edema patient who comes to you, what is your first choice of injection?
I can speak frankly, isn't it? I use maximum Avastin. This is the major drug that I use in my practice. I find that it is as effective as any of the other drugs available in the market, and I have the option of adjusting the cost for my patient.
Okay. And secondly, for AMD as well as DME, that is your first choice?
Yeah, that's my first choice.
Okay. And if
Secondly,
price were
this is
not
a
to be a
condition-
concern, we will hear from our legal luminaries about that very soon. But if price were not to be a problem, what is your first choice drug in DME and AMD?
I would say that Eylea would be my first choice.
In both?
In both.
Okay.
But this is a condition in which you have the option of performing surgery for the patient. If you do a routine vitrectomy itself, you are removing all the inflammatory sum that is there in the vitreous. And the half-life of whatever is there in the cavity is also reduced to significantly. So your patient does improve with vitrectomy.
Thank you, madam. So we will go to the next important talk by Dr. Thomas Cherian. He is in retina practice for 3 decades, and he will talk to you about the communication skills. That is the most important thing, because our patients will not get 6/6 like unaided 6/6 and 6 like our cataract counterparts who give absolute normal vision. So we have to tell and communicate with the patient regarding their prognosis. Over to you, Thomas, for your words of wisdom.
Thank you, Mahesh, for squeezing in my social studies talk in between these scientific lectures. I've been asked to talk on 3 pearls in communicating skills with a retina patient. Pearl number 1, give realistic expectations. Your patients come to you, the treatment could be either a laser or an injection or a vitreoretinal surgery. In any of these cases, or just observation in fact, or in either of these, you should give only a realistic expectation. Don't say everything will be all right with 1 injection, or you are going to read small print, and you in fact have to tell the patient that despite all these treatment, you are not going to read the small print. We are trying to make you independent. So that should be a realistic expectation in many cases. Another issue which I recently faced was, one patient came to me. He had gone to some other center. He had a diabetic macular edema, and the consulting doctor there told him that he might need 50 to 60 injections. What I would like to say is, don't scare a patient like that. You are talking about diabetic macular edema. Tell the patient that you need an injection. At the same time, don't scare him with these large numbers of 50 or 60. We have to tell them that many patients require multiple injections. It could be 2, 3, 4 or 5. But we have a few patients who have gone for 25 or 30 or even more injections. That's it. And don't scare him. Likewise, when you go for a surgery, tell him what exactly you expect from this and not to give unrealistic expectations. Pearl number 2, take the patient along with you and make him or her a part of your decision making. What I mean with this, a patient might come to you. You know fully well that this patient requires a vitreoretinal surgery, or he requires an injection, or whatever investigations to be done. But after explaining all this very lucidly to the patient, give him or her the freedom to take the treatment or to walk away from you. What I usually practice, I don't force a patient into treatment on the same day, except in one condition where a patient with a postoperative endophthalmitis is referred to you as an emergency. There, I more or less try to get the patient into treatment on the same day itself. And also to a certain extent for subfoveal choroidal neovascular membranes, AMD, where the time factor is very important. Otherwise, never force a patient into taking the treatment. He should have the freedom to walk away from you, take the treatment or not. And make him or her a part of the decision making. Make him understand what the outcomes of the treatment are going to be, what it would be if left without treatment. He might have so many questions whether alternative systems of medicine can help, whether a glass can help and all that. Explain very patiently, but the patient is the final judge on what treatment he is going to take. Pearl number 3, do not hide your complications or poor results. All of us are faced with situations when not all our patients do well, not all our patients come out with outcomes which we expect at the beginning of treatment. Sometimes we fail in our surgeries. Sometimes, despite our injections, repeated injections, the patient's condition might worsen. We have to discuss with the patient. First of all, we have to tell the patient that the surgery has not given the expected results. We have to discuss the patient as to ways and means to rectify it, whether he needs a resurgery, whether he needs a change of drug, if you are giving an intravitreal injection, all that. And if you feel that it doesn't stay within your hands, never hesitate to refer it to a colleague whom you believe can do a better job than you. Or at the same time, the patient also will have a confidence when he takes an opinion from another colleague. So that is referral whenever needed. So these are the 3 pearls which I would like to put across when you are communicating with a patient, when you are doing a vitreoretinal practice. Thank you.
Thank you, Dr. Thomas. Any comments?
When you talk to the patient, what happens is they tend to imbibe mostly the positive aspects of the surgery, and sometimes the negative ones don't go in that frequently. So do you encourage having family members also with you when you're discussing the problems and the complications that are possible and the outcomes of surgery? Would that be a help for the patient to make a decision?
Certainly, I would like to have the family members, not just when you discuss about surgery. Every patient when I examine, I get the patient's family member also along with him or her when I examine the patient, because might not mean anything, but when you propose a surgery, the patient will have to just nudge at the family members, the spouse or the son or the daughter, okay? And that nod is more important. That gives you the go-ahead or the green signal to go with the surgery. So that is very important, and the family member is also taken on board while making the decision.
Thomas, usually in larger centers, the medical counseling is a little different from the economic or financial counseling. But when you are a single person practitioner and things like that, how do you explain about finances to the patient? What is your advice to that?
I work in a larger center as well as I'm a single practitioner. So I've gone through both this. When you are in a larger center, of course, most of the things are taken care of. But there also I try to go to that medical counseling from my part itself, rather than leave it to the counselor. When you are a single practitioner, let me give an example of how you counsel for an injection. You have a lot of injections now available. When I'm talking about an innovator drug versus a biosimilar, I would like to tell the patient that there are 2 drugs here available for you. One is the original drug, which is imported, and the second is an Indian model, which is more or less the same. So you can take either. Now, when you want to go to the higher drug, you can say it costs little more, it costs this much. But then these are the specific advantages of this drug over what you have taken in the first 1 or 2 injections. So I would suggest that you take this if it financially suits you, and maybe you get a free injection after that. So likewise, I go for counseling for injections when I'm doing it from my side. Similarly, for surgery also, certain things you want to do, you want to use oil, you want to use gas, tell the patient openly what is the advantage of oil, what is the advantage of gas, and what are the disadvantages of both. And the cost also, there will be a little bit of variation in these. That's all.
Thank you, Thomas. Ultimately, if you see your appointment list and see the follow-up dropout, then you will know how good you are at communication. Suppose you have 50 appointments and 45 are coming every OPD, that means you have a very good communication skill. Suppose half of the patients are dropping out, your communication has some problem. This is one final test you can do yourself. Now I will welcome our Dr. Ashok Nataraj, LLB, who happened to be a veterinary surgeon also. So now he will give some pearls regarding legal practice, because I think all of us have encountered legal notices and we fight because we are not gods. We have our own bad results. So we will listen to Dr. Ashok Nataraj regarding some legal pearls in retina practice.
Thank you, Dr. Mahesh, for giving me this opportunity, and thank you, Drishti KSOS. Now, at the outset, the background for this discussion regarding legal pearls has already been said, because you know retina practice and outcomes after retina surgery is not absolute, and nobody sees the retina. See, you can show the cornea, you can show the lens, but you cannot show the retina. So when you talk about retina, it's like blind men talking about the elephant. Each person will imagine about retina in different ways, and finally what idea they have about the disease, nobody knows. So the first pearl I would like to say is the most important thing is avoid casual comments. And this happens when you're a doctor and you're a relative of the patient. So one patient will come and ask you, sir, I underwent retinal detachment surgery with the other doctor. Now I'm not seeing well. Then you say, see, that doctor has not put belt buckle. That is why retina has detached. All my cases, there is no problem, but that of doctor I know, because you're trying to show this one-upmanship, saying that, you know, you are better than the other. See, I agree, that's a very, very natural human tendency. And 90% of the litigations in retina practice comes because one of your colleague or some unsuspecting person has passed an adverse comment about you with the patient. Because when the patient comes for litigation or with a complaint to you, he will say the nuances. Sir, that infranasal brake you have not lasered. That is why retina has read it. Now, how will they know that infranasal brake has not been lasered? Because one of us has only done that. So you should always resist this temptation of one-upmanship and trying to say that, trying to show that you are better than. You have hundreds of healthy ways of showing others that you are better than the others. I think we should all avoid doing this. That is the most important thing. Now, this is one scenario where this is an actual scenario, a case of post-op endophthalmitis. It was a cluster endoff. So it was treated, it was referred to the retina surgeon, he also treated. Some patient recovered initially, then the eye went for evisceration. So this patient was sent for a second opinion to a higher center. Now one of the PGs there in the higher center says that, see, you've come a little bit late. If you had come earlier, we could have done something. So that is enough, no? See, just that small comment is enough, because when you're saying you don't know the background, what exactly has gone through, what exactly other person has, because you're also a surgeon, no? So this patient, what he did, he said, okay, I should have gone there earlier, this surgeon. And he not only involved the cataract surgeon, he said the retina surgeon also is not good, because that poor retina surgeon was only trying to help. He is also not good, so the complaint went against both the cataract surgeon and retina surgeon for deficiency of service. So the most important thing is, please don't try show your one-upmanship in all these things. Be patient. Try to understand what is the situation before you pass any casual or adverse comment, especially when the patient is your close relative. So that is the most important thing. Second thing is taking an appropriate consent. So this is something which has been really underplayed in our system, because consent is taken for granted. Unfortunately, many of the patients, when they file a consumer protection case, they don't talk about consent. So if they had looked at the consent, they know that for that particular surgery a proper consent was not taken, and not taking a proper consent is itself a crime, because it violates patient's privacy. So this is one incident that happened to me. This was a 75-year-old gentleman. He had a chronic retinal detachment. He was one-eyed. And patient consent was taken. I asked, is consent taken, everything okay? Then I had a doubt. I called the patient. I said, it's a one-eyed patient. I should take a video consent. So I started asking, what is your name? He barely told his name. Then I asked him, where you come from? I come from Trivandrum. Okay. What is your age? He said he is 20 years old. Then I realized that something was missing. So finally, when I started talking to him, actually this patient is suffering from dementia. So suppose you had taken the consent, written consent, and something happened, went for a case. See, the patient does not have the capacity to give valid consent, no? Because he is having dementia. So these are all small things. So in that situation, you should call the next of kin. sons, daughters, etc., and take a proper consent. So this consent taking, you should not take it for granted. And whatever eventualities, possibilities that can happen in that particular case, you should involve in the consent. Now, this is one important thing. Another scenario: a child suspected of retinoblastoma is got into the, for examination under anesthesia. Suddenly, you find that the retinoblastoma is very severe and the eye has to be enucleated. Now you have this paternal attitude. You take over the role of the parent and God for that patient, and you immediately enucleate. And you come out victorious saying that because I have managed your case, you did not require another surgery, I have enucleated the eye. Now the parents ask you, who gave you consent to enucleate the eye? You understand? So these kind of things should be avoided. Now, our post-cataract surgery end off. Now, okay, you did surgery, now IOL has to be removed, then only the end off will go. Now you remove the IOL and patient says, sir, I paid 10,000, 50,000 rupees for the IOL. You have removed the IOL without my asking. Only if, sir, you know, whenever, only if you put IOL, you will see, no? Yeah, yes, correct. Now you have removed the IOL, how will I see? So what will you answer the patient? So all these small things, no, you should take a proper consent before, because if you don't take a valid consent and do something out of this godly or paternal attitude, things are going to be very bad. So these are the different types of consent, and in India, what we follow is the prudent doctor test, in the sense that doctor has some authority to take a proper consent from the patient, and you have to inform reasonable things to the patient before you take a consent. So another important thing is, patient says, I don't want treatment. So in that situation, like if a patient comes with PDR, and patient says, I don't want any treatment for PDR. 6 months later, patient comes back with a blind eye. Now the relatives are, doctor, what did you do? You should have given treatment. No, he didn't consent. So in that situation, it is your duty to prove that patient did not give consent. So you document it there. Patient is not willing for treatment. And Pearl 3 is proper documentation and accepted protocol. So this is our famous ROP case. The only mistake they did was it was not documented there. There was the patient had to go for an ROP screening. The pediatrician did not document in the case sheet. Because of that, this case went against the doctor, and doctor had to pay a enormous compensation. Again, this is a post-endophthalmitis case that happened in Jipmer. What happened was they did not record the protocols. So what it was found was pre-op, povidone iodine was not instilled in the eye. On the day of when the patient came with intravitreal injections were not given. Probably these are all done, but these were not documented. And all these things went against the doctor, and they had to pay a compensation. So 3 things: avoid casual comments. Second, take a proper consent. Third thing is always follow proper documentation and follow accepted protocols. So in law, we say law supports only the vigilant. Law doesn't support lazy people, careless people. So it is your duty to be vigilant and not be dormant and come out with flying colors in your career. Thank you very much.
Thank you, Ashok. Very good talk. And we have sessions on medical law in the afternoon also. This needs lot of discussion. Probably we can deal with it later. I welcome Dr. Prakash, senior VR surgeon from Comtrust Calicut. He has immense experience in managing endophthalmitis, and he will be giving a few pearls in the management of endophthalmitis. Over to you, Dr. Prakash.
So good morning all. Thank you, Mahesh. So these are the 3 pearls which you have to remember when you face a case of endophthalmitis, which all of us as surgeons, whether we like it or not, will have to face. The first most important thing is have an early suspicion and diagnose it clinically. We don't have any supportive means to diagnose a case of endophthalmitis. You have to do it clinically and never go into a denial mode. Always think that it can happen to you and diagnose it early. Second is, whenever you have an endophthalmitis, do your maximum to identify the causative organism. And also the third thing is early and aggressive treatment. Endophthalmitis, everything is not lost. Still you can retain or regain many useful vision for these patients. So the first point, first pearl, diagnosis is clinical judgment. Because you have to decide, as Dr. Thomas was telling, we cannot postpone it to a next day. You have to decide when the patient is right in front of you, you have to decide whether it is endophthalmitis or not. So those are the clues from symptoms, signs, as well as a history of the patient. So the most common symptom is blur vision, but the most specific symptom is pain. So if pain is present, it is always in favor of endophthalmitis. But remember, 25% of the patients may not have pain and 15% may not have hyperpain. So first postoperative day, you have a case with it's very unlikely to be endophthalmitis, but if you see hypopion, then you have to think of it as endophthalmitis. After the first postoperative day, you've seen the patient on the first day, you've seen the amount of inflammation, then after that it worsens, patient still using drops, topical steroid drops, and it is worsening, then you have to think this could be endophthalmitis. And there are other clues, like you have to go through the history of the patient very carefully, pre-patient status. You look at the previous records, what was the status of the eyelids, was there any chalazion or anything which was done before, the surgery details, was it a prolonged surgery, was there a complication during surgery, all these things you have to go through, as well as clinical clues will be there, like if you see in the anterior chamber large white cells, and absence of keratic presence. Whenever KP is present, it could be a pre-existing uveitis that could be worsened. Presence of corneal infiltrates, vitreous exudates, as well as if you have fundus view and you see retinal exudates, hemorrhages or vasculitis, then it's almost always endophthalmitis. So with these clinical clues, you have to make a decision, and the biggest mistake I have seen is using B-scan, looking at the vitreous echoes and telling there is no endophthalmitis or there is worsening of endophthalmitis. Both are wrong, because vitreous echoes may be absent because for two reasons. One, it could be very early endophthalmitis where vitreous is only just getting involved. It may not be enough to cause vitreous echoes. First thing. Second thing is very fulminant organisms which like pseudomonas produce liquefactive necrosis of vitreous. Vitreous becomes liquefied. So you don't see much vitreous echoes. If you look at the top picture there, you see that there is significant thickening of RC complex. There is suprachoroidal fluid here, and there is that is almost like a panophthalmitis, yet you don't see much vitreous echoes. And see, after treatment the vitreous echoes has increased. So this does not mean that endophthalmitis is worsening. It happens when the endophthalmitis is responding also, because vitreous becomes more organized. The organized vitreous gives more echo. So that doesn't mean it is becoming bad. So this is one of the most important thing which you have to remember. But B-scan is essential, mainly because there could be a retinal detachment, which is a drastic complication of endophthalmitis, which you will have to diagnose. There could be masquerades like a retained lens matter, which also can be picked up only on B-scan. Second thing is, you have to go to any length to identify the organism, because for that particular patient it is important, so that you can give the optimal medical care for that patient. Also, you can make decision on early vitrectomy, because you identify a gram-negative organism, you would always go for an early vitrectomy. Also, you can prognosticate the disease. Medico-legal it becomes, remember, it's not that you caused endophthalmitis, it's not the medico-legal issue. The medico-legal issue is you have not taken a standard of care in identifying and managing it. So that is the biggest problem. So that to that extent, this will help you, and also prevent further outbreak. You know what is the organism, then you can prevent it if it is from your side, from your operation theatre. So the best and safest sampling method is taking an acid tap, which could be done by any anterior segment surgeon. And you always have a direct plating, because the yield even in the best of the eye institutes is less than 50% microbiological yield. So direct plating improves microbiological yield. So keep a plate, culture plate in your OT. Even if you have a small hospital, you can contact the nearest lab, who will be happy to keep a plate there, which they will take if you are not using it. Take back. And also keep a specimen back in your fridge for sending for a PCR if you don't get in routine microbiology. So it's very important to identify the organism. And third and most important is early aggressive treatment. So whenever you have diagnosed clinically there is an endophthalmitis, give an intravitreal antibiotic. That's a mainstay of treatment for endophthalmitis, because vitreous acts as a reservoir where your intravitreal antibiotic will lie, and it will, over the next 48 to 72 hours, it will release enough concentration of antibiotic to prevent further growth of the organism. And also keep the patient admitted in your hospital, monitor the patient every 4 hourly, and give systemic antibiotics with good ocular penetration. And the last but not least step is decide whether this patient requires an early vitrectomy or not, and if it requires, send him early to a VR surgeon for surgery. So here your decision making is dependent on what is the onset of the endophthalmitis. A fulminant, that is less than 4 days, is called as fulminant endophthalmitis. Then that means the organism is either very aggressive, or you have inoculated a large amount of organism along with the endotoxin, probably a contaminated fluid, into the eye. So these cases, not only treating the organism is not enough, you have to remove the endotoxins as much as possible, which is only possible by doing a vitrectomy. The other situation is the patient is not responding to initial intravitreal antibiotic. You assess for next 48 hours. If it is not responding, then you have to go for vitrectomy. And also if you have a complication like retinal detachment, you will have to refer for vitrectomy. So these are the 3 pearls: diagnose early, identify the cause, or make every attempt to identify the cause, and treat the patient aggressively. Thank you.
Thank you, Dr. Prakash. In summary, it is the value of time. You should not waste time, and systematic management as per the protocol. So, any question, madam? I invite Dr. Gopal Pillai for giving the next talk on intravitreal injections. Madam.
How do you explain the prognosis to the patient? Even if you have said that nothing can be done, they still expect something. So that is the major bear bug in managing endophthalmitis.
Never tell nothing can be done. We can do. We will. The prognosis we cannot predict. We will tell the patient we will do the maximum that is possible, but we cannot predict the prognosis. Outcome may be good or it may be bad. We cannot. It's difficult to predict in endophthalmitis cases. So never give a promise. At the same time, do not discourage the patient. Everything is gone and you cannot do anything.
Giving bad news is an art. So you have to first make the patient understand that we are trying maximum for the benefit of the patient. That is the first impression. Then, unfortunately, we are not able to tell the final this thing initially itself. With our long experience also, it is difficult because it depends on the organism. So give bad news slowly. It's an art actually.
Many times our problem as a VR surgeon is to protect the anterior segment surgeon. At the same time, we have to tell the prognosis also to the patient. So what I usually do is keep on asking the patient. Also, they will give some clue. Like somebody was telling the patient after the surgery, he went to a public toilet and you said that, did you do anything wrong? So he will think about it and I will tell I went to the public toilet and then that could be one of the, I will never tell that is the problem, but that could be. So that the honest, we try to put it lightly on the patient so that he won't get second thoughts like going to Ashok for medical legal help.
A word of advice to all cataract surgeons here: never talk in your theatre. Your patients are under topical or local anesthesia, and the patient knows exactly when the lens went down into the vitreous. And if there is any problem associated with the case, they will associate it with your loose talk in the theatre.
Oh, I want to
never
add,
ever talk.
Madam, I want to add there that one of the instruments fell down once. And then the nurse and the doctor had a casual conversation. Oh, thara poi, adu edukka. And then this patient, after 2 years, he met me somehow and he tells me that the IOL had fallen down during surgery. And then they had taken it and put it back in the eye. And that is why he has itching. Strange are the ways of counseling. Yeah. Okay, so thank you, Dr. Mahesh, for allowing me to present these 3 pearls in intravitreal injection. As you can understand, intravitreal injection, madam says 20 injections are now being given. So it has far surpassed the number of procedures. Any other procedures, probably non-contact tonometry and autorefractometry must be the procedures which are more frequently done than intravitreal injections. So there are lots of different types of intravitreal deliveries, etc. Anti-VEGF being the main thrust, but we do other for a lot of indications, including AMD. These are age-related macular degenerations or submacular hemorrhage, polypoidal choroidal vasculopathy, radiation maculopathy, retinal vein occlusions, diabetic macular edema. So all these are indications: proliferative diabetic retinopathy, advanced PDR, and even in endophthalmitis or antiviral sometimes and steroids. Sometimes we do inject gases, anti-cancer drugs, vitreolysis, and now coming on to newer things, stem cells and gene therapy will also be intravitreal. So this many procedures being done, and especially in a busy center, there's going to be about 10 to 20 injections every day. And Pearl 1 is identity. You have to identify the patient, you have to identify the eye, and you have to identify the injection. Because any mistake there is unpardonable. It is like operating the wrong foot or taking off the other kidney which is normal. It is completely unacceptable and unpardonable. So the surgeon will be scrubbed up. The surgeon will have some 10 or 15 injections to go, and then there may be some few surgeries to do. So the theater is busy, and there will be somebody bringing that patient onto the table, and the patient will be in cap, mask, sometimes all those things, and the patient will be lie down, and maybe the surgeon is so fast that probably he will only see a draped patient on the table. it is extremely important to look at identity. So both eyes may have a problem. So we should know which eye is the problem. So we have to earmark that particular person, probably the tag, and probably when the patient lies down, you should ask the patient's name. And sometimes the patients may also be apprehensive and they may not come out with a name also. So then you should have that idea that this is this particular patient and ask the patient, are you so and so? See, sometimes if you ask, so, are you so and so, he may be apprehensive about the injection if he's a first timer or something like that. So generally have a tag of the patient's name, and the eye you should mark very, very clearly so that we don't mistake the eye. And get the file of the patient, or get the printout, or get a small sheet done in which patient is getting which injection. So these three things, identity is a very important. So these are some of the identity markers. Patient identity with tags. You can have a good mark, either this or maybe something which is white plaster which is put there or something like that. And drug identification with the case sheet. Probably you can just before the injection. During the injection, please do not talk much, because there may be, because even if we are wearing a mask, it may be better not to talk too much. But before the injection, please do ensure that the correct injection is going in. Pearl number 2, asepsis and pain management. Okay, intravitreal injection is something in which you are directly injecting whatever it is into the vitreous. And if it is an infection that you're bringing in, it is immediately going to be, in fire. The endophthalmitis of a intravitreal injection is also very, very rapid, and it can actually be very devastating. You can lose the eye. Many patients with diabetic macular edema or AMD with good vision with 6/12 or 6/9 after an end-off will go to, hand movements, something like that. So asepsis is a very, very important thing. Location usually is the OT, but a clean room without any contamination is acceptable. Set up all aseptic precautions. Whatever you do for cataract, you should have here. Preoperative preparation, informed consent, pupil should be dilated, and topical anesthetic agents do really well, because if the patient is in pain, he will not come back for the second injection or the third injection. So, maximally reduce the pain, use lid speculum, and very, very clearly put betadine 5% or 10% on the cornea, on the ocular flora, so that we have. And 3 minutes contact time is what betadine will do. So 3 minutes contact time is what we need to do, and then give the injection. Pearl number 3, drug dosage and IOP management. See, we have a 1 ml syringe in which we require 0.05 ml usually to go inside the eye. So in a 1 ml syringe, if you have 0.1, if you draw it to a 0.1, there are some space in the hub of the syringe as well as in the needle. There is some dead space. So make sure that you put your this dead space is filled with medicine, and then your piston goes up till about 0.05 ml, so that only that much volume can go in. And usually with that volume, the pressure does not rise. But if it is a glaucoma patient, or if it is a patient with a problem, a labile disc, basically get that. Okay, and this is a small video of injection. These are the 3 pearls that I would say. Number 1, identity. Identity of the patient, of the eye, of the medicine. Number 2, asepsis. Absolute aseptic precautions and pain management. Number 3 is correct dosage going inside the eye. So make sure that the needle does not touch anywhere, not even the lid margin. Directly go to the center of the eye and inject. And if in case of doubt, maybe you can take a bit of aqueous out by doing a paracentesis as well. Thank you very much.
Thank you, Gopal. This talk is very important because nowadays a lot of people are doing cataract and medical retina specialty, and the number of injections are increasing. We see more complications like endophthalmitis also in the last couple of years with the advent of biosimilars, which are being used by a lot of people. So thank you, Gopal, and we will go to the next talk by Dr. Biju Raju. Dr. Biju will be speaking on some salient features, pearls in the management of, the interpretation of OCT. Over to you, Biju.
Thank you very much. I have no financial disclosure to be made. My first pearl on OCT would be to know your scan and never to rely on a single scan, and also to rely more on the grayscale than the false color code of the image. And if you are going to rely on a single printout or a single scan of the OCT, then you are missing out a whole lot of things on the retina. As in this case, we would think this is a maculopathy with a subfoveal serous retinal detachment. You might plan injections, but this is actually a macular hole. But why did that happen? Because the scan line actually goes above the macular hole, which gives you this impression, whereas this is what is actually the condition of the patient. So be very careful when you interpret images with just one scan. It's not the proper way to do. You might end up in trouble. And OCT is essentially a representation of the reflected light, the intensity of the reflected light. And the grayscale is actually the intensity in levels of the brightness. So which makes it an ideal way or a mode to look at the kind of layers and changes in the retina with OCT. When you have color, it's a false color coding, and they have color hues for the different brightness. And that makes for lesser contrast sensitivity, and color distracts your perception, and you miss certain textures. Studies have shown that grayscale images are far better in evaluating OCT scans. And when you look at this picture here, you can see that once the color is gone, the layers just pop out, and it's very easy to identify the different layers. My second pearl would be to see the layers. When I say see the layers, I would say see through the layers and see beyond the layers, because we all know what the layers of the retina are and how they appear on OCT. But we should understand that they are all reflectivities, and the bands that come on OCT can be correlated or cannot be correlated certain times with histopathology. For example, when you look at the ganglion cell layer, it's a hyporeflective layer that is well correlated with its counterpart on the histopathology slide. But when you take the case of ellipsoid, which is packed with mitochondria, we would think that the line, one of the lines in the outer retina is the ellipsoid, but still there is no consensus. We don't know as of now whether that line is caused by these mitochondria containing ellipsoid zone. So they are parts of the retina which we don't have a clear correlate when you look at the histopathology. So they are divided, these layers are divided into bands and zones. When you have a clear-cut evidence, a clear-cut layer with a clear-cut evidence on histopathology, we call them bands, which are well defined, and which don't have a strong correlation histopathology, like the ellipsoid, you call them as zones. And as a general rule, all cellular layers are hyporeflective, and all synaptic and nerve fiber layers are hyperreflective. So it's no surprise that when you look at the hyperreflective band, all the synaptic layers and the nerve fiber layer, along with RPE, of course, with the melanin, is hyperreflective. They are the bands. And the hyporeflective band, as you guessed, it's all the cellular layers of the retina. And the zones, the hyperreflective zones are the ellipsoid and the interdigitating, and the hyporeflective being the myoid and choriocapillaries. These are layers on the retina. We clearly don't have a clear-cut idea what is actually contributing the band on the zones in the retina on OCT. So this is a summary of the facts that I just mentioned, and this is well described in the article by Dr. Munna Bende in Indian Journal of Ophthalmology. My third pearl would be to look for the biomarkers. In OCT, there are two biomarkers, but two classification of biomarkers, that is the fluid biomarkers and the structural. The fluid being based on the distribution of the fluid in the retina as intraretinal cyst, subretinal fluid, and sub-RPE. We know that intraretinal cyst or fluid are more dangerous than the subretinal fluid, which some authors say are protective to the status of the retina. So when we know the level of the fluid and the status of the fluid level, fluid in the retina, we know that you can have a prognostic outcome. We can prognosticate the outcome after treatment of those patients. And the structural changes could be retinal or choroidal, and these are the few of the retinal biomarkers. We can see the drill, which is having a poor prognosis, the double layer sign, which can say that there will be more exudation, but they can respond well, and integrity of the photoreceptors based on the external limiting membrane, ellipsoid, and the interdigitating zone. So the damage occurs in this direction, and when they start recovering, the ELM comes first, then the ellipsoid and the interdigitating zone. When you have PEDs more than 550 microns, you have to be careful, and if it is especially a fibrovascular PED, then there's a high risk for retinal pigment epithelial tears, which can lead to a poor vision. And the choroidal biomarkers, we are getting to know them better, but we all know about the choroidal thickness, which is important to identify pachychoroid syndromes. So when you look at the summary of these factors, most of them are poor prognosis factors. When you look at that and see them in the scan, you know that the outcome is not going to be very good. But certain things are of good prognosis also. And the photoreceptor integrity guides you on how the visual improvement is coming through. These are my 3 pearls on interpreting OCT scans. Thank you very much.
Thank you, Dr. Biju.
Now I invite Dr. Mahesh Gopalakrishnan. He's not a stranger to us. He's one of the most prolific retina surgeons in Kerala, and he heads the retina department at Giridhar Eye Care Center. Now I invite Dr. Mahesh Gopalakrishnan for his talk. Thank you.
So this is one of the topics which is close to our heart. Actually, Dr. Giridhar was supposed to give. He had to go for an examination in PGI. So I am giving on behalf of Dr. Giridhar 3 pearls in the management of PCV. PCV is polypoidal choroidal vasculopathy. Okay. First one is PCV and neovascular AMD, that is wet AMD, is not the same. That is the pearl 1. Many of us, for everything there is only injections, then what is the big problem? So it is not the same. Why? Because PCV happens in younger patients, 40s and 50s also, and they lack drusen, which is a characteristic sign of early AMD. And the responses to treatment also is different. Now, the PCV can run a benign course, like sometimes the polyp will be there, non-leaking polyps will be there, and then branching, but it may remain like that for a long time. Only problem with PCV is sudden hemorrhage, causing sudden vision loss. Otherwise, it can run a benign course. We need not treat every PCV unless it is leaking or exudation is there. But neovascular AMD with a CNVM usually runs a more aggressive course, difference 1. Then the network also is a little different. In PCV, usually you get a thick choroid or pachychoroid with large halar vessels, and there is no drusen in PCV, and usually the scarring is minimal in PCV unless there is a hemorrhagic complication and resulting in this. So the neovascular AMD on the other side affects the retinal pigment epithelium and Bruch's membrane and choriocapillaries. But here the RP gets PCV affected secondary to hemorrhage or exudation. So it's not the primary. So this is the difference between PCV and AMD. And the vessels in PCV have larger vessels, mature vessels, more polyps and branching vascular network, and there is an element of arterial involvement also. So now second pearl is, so how do you know which is PCV, which is neovascular AMD? You look for biomarkers. Even though the gold standard for diagnosis is ICG, many of us will not have ICG. Look for the biomarkers. So these are standard things. Orange nodule in clinical photo. Then that PED, the tubular PED, thumb-shaped PED, sharp-peaked PED, nosed PED, it's a nosed PED, and double layer sign. It is actually a double layer sign, hyperreflective double layer signs. The Bruch's has gone up and there is this is separated. So inside that there will be hyperreflective. So hyperreflective double layer sign, and sometime in NVAS of OCT also you see that. So these are some of the biomarkers that will tell you are dealing with PCV along with pachychoroid and pachyvessels. While in CNVM you get these sort of subretinal fluid, photoreceptor degeneration, you get photoreceptor degeneration, hyperreflective dots corresponding to exudates, outer retinal tubulation, SHRM, subretinal hyperreflective material, maybe vascular or then retinal pigment epithelial tears and rips. So these are all more features, especially in IRF, features of neovascular AMD. Now pearl 3 is go for combination therapy in PCV if possible, not always. Nowadays the standard of care for PCV also is anti-VEGF monotherapy, because different studies are there. But I will show one example. This is a case. You can see there is a thumb-shaped VAD with a little hemorrhage, fluid, subretinal fluid, and ICG is showing here there is a bunch of polyps here. You treat with 3 injections, it has reduced, but it is not going. So after that, again do the angiogram. You can see the cluster of polyps beautifully now. Since it is not responding, switch to photodynamic therapy, and with photodynamic therapy, it collapses, and there is regression of the polyp. And later, after few years, 2 years, it starts again. PCV also will come back. It is not that PCV is more curable than NAMD, but you get a space of less injections with PCV if you do a combination therapy. Again, new polyps are coming at the edge, creeping polyps. So again, repeat PDT and injections, and then it goes. So again, it is coming back after 2 years. So in other words, PCV has less aggressive course unless there is a hemorrhagic complication, and if PDT not available now, sometimes in the peripapillary cases you can give thermal laser also, which also will be helping to reduce the number of injections. So these are some of the differences in PCV and AMD and 3 pearls. So thank you very much for attending this session in large numbers, and I thank especially Meena madam for coming to this session. Any comments or any this thing? We have 5 minutes, almost time. Okay, so Aparna is so thank you very much for attending.